is a pleasure for me to welcome you to the first of the Urban Health Institute's quarterly seminar series, this year focused on community-level interventions that improve the health and well-being of children, youth, and families. Richard Catalano, or better known as Rico, is a friend and colleague to many of us here, certainly myself, and someone whose work I have known for an extended period of time and who I have had the pleasure to know directly for the past 10 years. The work that he and his colleagues have done in the Seattle Social Development Research Group, I guess when you're in Seattle, they drop off the Seattle part of the Social Development Research Group at the University of Washington, has really been some of the landmark research in youth-based programming. While he and the group now is best known for their very extended community-based intervention and program that he'll be talking about, Communities That Care. In truth, some of the research that has come out of the Social Development Research Group both predates those initiatives and also goes beyond it. Rico is the Bartley Dobbs Endowed Professor for the Study and Prevention of Violence at the University of Washington. He is head of the Social Development Research Group. He has had a very long-standing, we learned earlier today, a 30-year collaboration with J. David Hawkins, and together they have really, I think, done some of the very landmark work in the United States. One of the things that we know is that programming for children and youth is often advanced with very little science and with a very high level of gut level of appeal. So if it feels right, we tend to do it. And despite the fact that evidence might show that it doesn't work, we tend to do it more. And we have numerous examples in this country of how we have done that. The Communities That Care is perhaps the most rigorously researched community-level intervention that has been conducted over an extended period of time, over an extended number of communities. What we will do this afternoon is hear about those initiatives. And then we have a very distinguished panel, and I will introduce them after Professor Catalano speaks, and to reflect on the lessons learned as it applies to Baltimore. While this is not an official Baltimore Week event of the school, it certainly is Baltimore Week here in the School of Public Health, and being able to look at initiatives such as Communities That Care and think about what does it mean here in our city for children, youth, and families is critical. I think it's critical that we learn from evidence-based studies and evidence-based community programs. So Rico, thank you very much for coming. Thank you for sharing with us your perspectives, your experience, and your data.
Whoa. Lots of stuff on this podium. Okay, we'll do that. We'll figure it out. Thanks. Thanks, Bob. What a lovely introduction, and thanks for inviting me to take part in the discussions today. We've had earlier discussions this morning with many key leaders from around the city area. who are interested in the positive development of Baltimore's youth. And it's really an honor to be here and to, as you'll learn, to have such a distinguished panel of commenters commenting on the work that David Hawkins, Kevin Haggerty, and my colleagues have done at the Social Development Research Group. It's been clear to me from this morning's activities and my activities a year ago that Phil Leaf brought me in to talk to various officials from the city. It's clear to me that there's a lot of interesting and impressive work that's been done in Baltimore, and there's many elements in place that are necessary for the success of such youth development efforts. So I really applaud people in this city and this university as well, and the nice university community partnership that's developing. I want to share some work that we've undertaken at the Social Development Research Group over the last 30 years that has informed our understanding of how to promote positive development and prevent problems community-wide. And we'll focus on that community-wide part. I've spent a lot of my career doing a couple of things. The first thing that I've done is try to understand what are the factors that predict positive development and good experiences for kids, and what are the factors that predict problems that get in the way of healthy development. What are things that predict substance use, violence, teen pregnancy, early school dropout, many problems like that, or serious emotional problems among kids. Many academics are happy to stop at that point and say, well, we know what the causes are, or the potential causes of these problems are, and we know how the things that promote positive development. We'll leave it to everyone in the audience today to figure out what else to do about that. We've tried to, as many of our colleagues increasingly have tried, to use that information on predictors to develop and then test prevention approaches, and we've developed a variety of prevention approaches, both family approaches and school-based approaches, as well as communities that care, that I'm going to be talking to you about today. I think that the good news is, as a result of research done by the Social Development Research Group, Johns Hopkins School of Public Health, and many others across the country, we have a strong and growing research base for positive development and the prevention of problem behavior. We've developed an understanding of the things that predict problems and predict positive development, and we, as a result, we've been able to better target our preventive interventions to try to reduce those risk factors and increase protective factors over time. I think that the challenge for the 21st century now becomes, how can we, as responsible stewards of public funds, actually pick the best programs for kids in our communities that we're responsible for? When I started my career, it was like, well, nothing works, so it doesn't make any difference what you do. And now we're in a really different situation, trying to match the right program for the right needs in our community. And I hope to answer this question by doing a couple of things this morning. The first thing I want to do is provide a little overview of the knowledge base for prevention science, and I'm going to talk to you about what we know about risk and protection, and also what we know about effective programs as well as ineffective programs. And then I want to share in the second part our model Communities That Care, and I'll just try to give a brief overview of the program and in its results. But we've really been developing this model for the last 20 years. We started developing it in 1989 when we said it's not enough to develop an effective program. We know how to do that, but this isn't the only solution, this one program for everyone's needs. And a lot of other people have developed programs. How can we change our approach, sort of turn it on its head and say, how can we help communities choose the right programs for their needs in their communities? And all communities have different needs. We've been probably implementing this program in over 300 communities in the United States, the United Kingdom, Australia, the Netherlands, and Canada. And we've learned a lot, and in fact, our best and hardest lessons and probably most productive lessons have been learned from community members saying, I can't figure it out, Rick, how do you do that? Let's think of a different way. We need a better display. We need better this or that and the other. So what you're seeing is the result of 20 years of work. It may seem, oh, of course, yes, that's right, but it's really been learned at the feet of community members who've helped us do that development. The great news is that CTC is now owned by the federal government. It's part of the Center for Substance Abuse Prevention. It's on their website, so it's freely available to anyone, much more available than it's ever been in the past. So that's a wonderful thing for that. So I want to orient you to our work. And I first want to recognize, or we all have to recognize together, that there's various places that you could, whoa, this is, School of Public Health has a really big instrument. This is this is like, this is physical activity as well, I see, okay. This one costs a lot more than my little pen model. You can start at many different places in the spectrum. I actually started my research and program development career over here in the treatment and aftercare end of the intervention spectrum. I often found, but I now have worked more in this promotion and prevention area, and I think that my passion for working on this side is because when I was working over here, kids had already experienced the reinforcing effects of alcohol and other drugs. They had already experienced school failure. And if they were adults, they had no interest in legal work. If they were kids, they were in serious conflict with their families. And if they were adults, they were in serious conflict with their own families, and often leading a whole new generation down that path. Treatment and aftercare interventions are important work that has to be done. I don't mean to say that people shouldn't be involved in there. I just said I need to work on the front end of this before all these costs to the individual and society occurred, to their impact on friends and families, their schoolmates, etc. Wasn't there something we could do beyond running an ambulance service at the bottom of a cliff underneath a sharp curve, where we could pick those kids up and patch them up one at a time? But wouldn't it be better, I'm sorry, I'm going to move a little bit over here. Couldn't we put up guardrails on that sharp curve, something to prevent the car from going over? Or take a step even further back and put up signs that say, dangerous curve ahead, please slow down. Or take a step even further back. I can't get away from the microphone, so they told me I'm filming. Is it okay? Can I move back just a little? No, he's shaking his head. He's hating me back there. And even move back further and say, let's do good driver education for kids, and let's make sure they can before they even get in the car, they recognize conditions and situations that are dangerous, and let's then put laws in place that do graduated licensing, so kids, get enough supervision before they get their license, their full license, and then the full license isn't really full. It's actually something that we say, you can't drive at night, and you shouldn't drive with peers for the first bit of time because you need more experience in driving before you do that. And best, couldn't we do all those things? The kind of target hardening situational thing by putting the guardrail up, putting up signs and letting people know publicly, doing good training, and changing the laws. So I became an advocate for the concept of prevention and trying to develop an effective approach to prevention. Now, many of us are advocates for prevention and promotion, but what we've had a harder time coming up with is how to do effective promotion and prevention. And we know that just working as hard as you can and trying to make a difference, even if you're well-intentioned, doesn't necessarily get the job done. There's a lot of programs that have shown to be evaluated, even done by well-intentioned people working hard to prevent problems, that didn't have much effect, if any at all, and some had negative effects. And these include many popular programs that many people are excited about. So if we're going to develop an approach to prevention, how do we do that? Ben Franklin is the first guy that gets credited with writing down the old adage that an ounce of prevention is worth a pound of cure. And that's an interesting adage, and I like this expression of that adage. Calvin and Hobbes, people probably don't remember Calvin and Hobbes anymore, but they've been out of the paper for a while. Calvin's a little boy, gets in a lot of trouble, and Hobbes is his imaginary tiger pal. And Calvin says, "Live for the moment's my motto. You never know how long you've got. You could step in the road tomorrow and wham, you get hit by a cement truck. Then you'd be sorry you put off your pleasures. That's what I say. Live for the moment. What's your motto?" And Hobbes looks at him and says, "Look down the road." If you're going to try to prevent problems in the future, you have to look down the road at the consequences of your experiences today. But if prevention is going to go from an old adage and a cartoon, perhaps, to a science, it needs a couple of things. The first thing it needs is a framework. And the prevention science framework is rather simple. It says we have to figure out first what problem are we working on, and then identify the things that increase the likelihood of those problems, like risk factors, and those things that promote or protect kids who have the problem even in spite of risk. Those are protective factors. So if you're thinking coronary disease, we can all rattle off the risk factors for that, high cholesterol being one risk factor. If you're thinking of a protective factor for coronary disease, it might be exercise. So you think of that as a protective factor for coronary disease. Well, we're not thinking about coronary disease, but they, oddly enough, it did the research a lot before we knew a lot about these youth development risk and protective factors that have only really been discovered in the last 30 or so years. So if we know what these risk and protective factors are, we can then put interventions in place to reduce risk and enhance protection. And then if we implement our program well, if it works, it should be evaluable, and we should see decreases in risk, increases in protection, and changes in the problem that we're interested in in reducing rates in the population of those problems for those who get our interventions compared to those who don't. There is a growing and burgeoning knowledge base in prevention science that makes this prevention science framework possible for youth development and the prevention of problems. There's a lot that we know now, much more that we know now about risk and protection than we knew when I started my career. I remember being at the American Society of Criminology, and there was a large debate going on about whether to fund any longitudinal studies because they were so darn expensive. And you could do 10 cross-sectional studies for one longitudinal study. Well, we won that argument, and it was really not just us, but the field won that argument. And as a result, we know a lot more about these risk and protective factors. I'm going to go through these rather rapidly. We've published about 12 articles on these. These are the different problems that we've investigated: substance abuse, delinquency, teen pregnancy, school dropout, violence, and depression, and anxiety. And these are the risk factors along the rows, and these happen to be community risk factors. And again, I won't go into detail here, but just to show you that if this is availability of drugs in a community, the higher communities can put their kids at risk. If there's a lot of drugs available there, kids in those communities have higher rates of substance abuse in adolescence and higher rates of violence. There's a lot of things that are pretty obvious to us all, but there are things like transitions in mobility that we might know as much about. A lot of in and out migration also increases the likelihood of, in a community, it increases the likelihood of substance abuse, delinquency, school dropout, and depression and anxiety. And here's one we all know about, poverty, and it's a pretty pervasive risk factor across all of these problems. No area of socialization will be untouched in risk. There's a lot of things that families can do to increase the risk of that their kids will have these problems, including having a family history of the problem. Again, family history of the specific problem increases the likelihood of that problem. Family management problems, again, pretty pervasive. If you want to know what family management problems are, I like to think about what good family management is rather than the problem end of it. It's making sure you set good guidelines for your child, that they know what your rules are in your family, and they know why you set that rule. It's important that you give a rationale. The second thing that you have to do, if you know what you want, you got to look for it. So you got to monitor your kids' behavior and understand, are they doing what you want? Are they following the rules? And if they are, you should recognize them. That's the third part of good family management. Recognize that hey, you're doing a good job. That's great. You're following the family standards in this area. And if they're not, finding ways to provide moderate consequences, negative consequences, so that they understand and can correct their behavior. When families don't do that, those three things, if they don't set guidelines, monitor, and moderately consequate or positively consequate good behavior, those kids are at risk for this entire range of problems. Family conflict is another fairly obvious one that I won't go into much detail again, but you can see the family risk factors, a lot of common risk factors for all these different problems. In the school, again, a set of checks across the columns. Academic failure beginning in late elementary school, and then lack of commitments to school generally beginning about middle school time frame are pervasive risk factors for most of these problems. When we get into the individual and peer factors, these are the ones we know more about often as lay people. I know that many of you aren't lay people and you're quite involved in this field, so you know these risk factors, but they're things like early aggressiveness, rebelliousness, hanging out with friends who are involved in these different problems. And these things tend to happen in that middle school to high school time frame, developing a favorable attitude for the problem behavior. These attitudes change from elementary school when kids say, drugs are stupid, why do you think they call it dope? I don't believe in that. But when they get into the beginning of middle school, all of a sudden Bobby and Jimmy and Mary are doing it, and they didn't turn into monsters. Maybe I should try them too. So these favorable attitudes become risk factors around 6th or 7th grade. And then finally, an early initiation. And the last one here is constitutional factors. These are often biological or genetic factors. This is not listed in developmental order. It can affect a child from birth. There are things that may be indicated by kids who are sensation seekers or impulsive, and they predict substance use, delinquency, violence, and depression and anxiety. The good news is that there's also predictors of positive outcomes or protective or promotive factors. And this research has been done by studies of risk. We know that risk factors are just risk factors, right? They don't condemn someone to having a problem. So, for instance, even a very strong risk factor like family history of alcoholism, we know is a fairly strong factor. It's 2 to 4 times the risk, particularly from fathers to son, increases the risk if your father has an alcohol problem. But at the high end of that percentage, it's about 29 or 30% of those kids who have a father who's an alcoholic develop the problem. That's still 70% don't. So there's still some idea that there's something that's protecting those kids in those environments. And so researchers started trying to understand what protective factors were and how they operated, that even kids exposed to a number of risk factors did not develop problems. And so they identified these protective factors. They're both individual characteristics like high intelligence and an ability to bounce back from adversity, a resilient temperament, as well as a range of competencies and skills. Beyond the individual themselves, in each social domain that kids grow up in, like a family, like school, like peer group, or like neighborhood, if neighborhoods provide positive opportunities, and it's a rich neighborhood, not rich necessarily with money, but a rich neighborhood of opportunities, lots of positive things for kids to get involved in, they tend to be protected. If adults in the community and their peers reinforce them for getting involved in positive activities, that's also a protective factor. Forming strong bonds between those adults in the community with kids, that's another protective factor. But particularly if those people they're forming bonds with are actually positive individuals who hold healthy beliefs and clear standards, because we know gang bonding occurs too. This is pro-social bonding or bonding to those who hold healthy beliefs and clear standards, whose families say to their son or daughter, look, it's important. I know that education is important, and you have to make sure that you do well in school. If those same kids, even if they're living in high poverty areas or high crime areas, but go to schools where teachers say all kids can learn, everybody can learn here, And if teachers and parents agree that violence isn't a way to solve problems, that they have other ways to solve problems, and that drug abuse is bad and harmful and unhealthy, those kids, if they're bonded up to those who hold healthy beliefs and clear standards, are really held in closely and protected by those living in their community. Sometimes it's family, sometimes it's school, sometimes it's community or positive peers. But the more areas of bonding occurs, the better. But sometimes just that single positive person has really been a very important element in these kids' lives. So risk and protective factors are important. Professor has to demonstrate that with data. I apologize. This is done with a survey across 6 states, over 80,000 students in grades 6 through 12. It looks at different problems, outcomes. This is alcohol use in the last month. And down here, those with 0 or 1 risk factor, less than 20% of them are involved in alcohol use in the last 30 days. With 10 or more risk factors, almost 75 to about 85% are actually using. And protection has its influence at each level of risk. So here at 4 or 5 risk factors, those with 0 or 1 protective factors, about 50% of those kids are using. You get more protection in a kid's life, 4 or 5 protective factors, about 28% are using. So it's about, reduces it about half. So risk increases use, protection decreases use, and it doesn't make any difference which problem you look at. Well, you can look at marijuana use, a very similar curve. You can look at youth violence, another very similar curve. We've been working with our colleagues in Australia who are interested in different things than we are. They're interested in more internalizing disorders and risky sex, and so they said, let's see if the same risk factors predict. So they found that risk increases depression, risk increases early sexual activity, youth homelessness, and deliberate self-harm. And we've been doing some work in Washington State because we know that schools are important in prevention, and getting kids exposed to prevention programs that are delivered in school is an important thing. And we've been having a hard time with No Child Left Behind. People are saying, oh, we got to do all this academic stuff. But we can also show them, and this is in our state, again, about 80,000 students in our state, and looking at this is our standardized achievement test score. It's called the Washington State Assessment of Student Learning, or the easy-to-remember acronym WASL. Don't ask me why they named it that way. But in any case, here's those with 0 risk factors. About 75 to 85% are meeting the grade standard. This is among 10th grade students for math, reading, and writing. And those with more risk factors are actually, very few of them are less than 30% are meeting the grade standard at that other end of the continuum. And there's graphs for both of those things on protection, and it has the same kind of effect. So there's a variety of factors that are shaping kids' development. Parents are affect kids from early on, but all the way through high school. We know that parents actually have impacts of kids into young adulthood as well. We know that the school is the next thing that comes on board as kids enter school in 5th or 6th grade. Then peers in the middle to the end of elementary school become influential, and in community, usually when kids get into middle school and start ranging a little further from home. And what we've noticed is that there are 2 different patterns of risk development. The first one is what we call, John and I have called a snowball pattern of risk, where early risk accumulates through developmental challenges that kids have. They may have problems in the family. Those problems often make them not ready for school. They begin to have problems at school. They start hanging out with other kids that are having problems at school. You get the picture of kind of a snowball pattern of risk. That has a different set of intervention implications than the second one, which is even kids who aren't exposed to those early, developmental challenges, but are exposed to positive norms towards problem behavior and other models of problem behavior without a lot of protection, without, people holding them in, without strong bonds and healthy beliefs and clear standards in their lives, and a lot of opportunities for positive action. They can stand out in the snowstorm and eventually you're going to succumb, right, to risk in this case. So there's a second pattern of risk that's really more of an adolescent, and he's pushed over here because it's more of a middle school, high school pattern of risk, and even kids without these earlier developmental challenges can succumb to adolescent problems during that time frame. The other thing is, and this we learn from communities every day as you work with communities, my community is different than yours. Your community is different than mine, and everybody here lives in a different community. I'm sure they're different than each other. Different neighborhoods have different profiles of risk, protection, and outcomes. This is demonstrated in this topographical display of data. This is Redlands, California, and we've displayed risk in topography. So you have mountains of risk, if you will. And there's two neighborhoods that have the highest levels of risk. This one is much higher than this other neighborhood. This is the low-income, high-crime neighborhood in Redlands. This is a more affluent neighborhood. And it appeared to us when we looked at the pattern of risk underlying these mountains of risk, how many risk factors they're exposed to, that this was more of a snowstorm pattern with those early developmental challenges. And this was more of a snowball pattern, and this was more of a snowstorm pattern with those adolescent availability of drugs and favorable attitudes towards drugs, disposable income, and no parental supervision, and that was what was driving risk in that neighborhood. So the idea here is that different risks are driving risk is not distributed on an equal opportunity basis. It's a very different distribution, and that means that different neighborhoods need different kinds of interventions. So what does that say about what we know about risk and protective factors? Risk and protection make a difference. We have our great good fortune is that these common risk and protective factors predict diverse problems. So you saw family management predict all these different problems. So that means if we make a change and we could try to get parents to be better monitors and better guideline setters and better consequators, I don't know if that's a word, give better recognition and moderate negative consequences when kids don't follow the rules, that we should be able to have an impact not only on substance abuse, but on youth violence, on teen pregnancy, on dropout, et cetera, because all those checks were all along that column in that graph that I showed you earlier. So this is great. This is a good thing. If they were all separate, we'd have to be in our silos, which of course is how we usually distribute money. But we don't have to be. We can combine that money in these ways. Risk and protective factors show much consistency across diverse groups, whether you're talking about income groups or cultural groups. These factors show much consistency in their impact. Different factors affect youth as they develop. I've just talked about the snowball and snowstorm. And different neighborhoods have different levels of risk and protection. So we can use all that to design interventions. Some interventions will have to be designed to counter a snowball pattern. Some will have to be designed to counter a snowstorm pattern. Different particular interventions are indicated in the family versus school versus community versus peer group. A lot of us around the country took that information and said, okay, we might now be able to develop some effective prevention programs. I started my career when I had hair, and it was all one color. You might not know it. It was black at the time. It's now all different colors, but mostly I like it if it's even there anymore. But when I started early on in my life doing this work, we were asked by the Office of Juvenile Justice and Delinquency Prevention in the U.S. Department of Justice to review all the delinquency prevention and substance abuse prevention programs that were done that had a strong enough evaluation to tell if they made a difference. First of all, there weren't many of those. There were only 23 had a strong design. And of those, not one made a difference. So it was a different point to be in at that point. And now that we have all this knowledge about risk and protection, we can use that to design interventions. People have been busy. Both the federal government's been funding this, and people have been designing and testing interventions, and we know a lot more about what doesn't work. And I hate to put this slide up because everybody has their favorite thing that they would like to challenge me on. But remember, this particular work is done by the U.S. Surgeon General and the National Institute of Justice. And Denise Gottfredson, she's just down the way at College Park, so you can blame her for this list. But there are lots of things we know that don't work, both in universal prevention and selected and indicated prevention. I can now put DARE down, new and old. I only used to be able to say, oh, it's the old model only. But now we know both models don't work. But let's not focus on the negative, folks. Let's focus on the positive. Wide-ranging interventions have been shown to be effective. Things from early on, prenatal and infancy programs, to early childhood education, parent training throughout children's lives, things that happen in the community like after-school recreation, mentoring, and youth employment, things in schools like how schools are organized and how classrooms are organized and managed, and how the whole school it looks at behavior, as well as particular classroom curricula for promotion of social competence that often are the kinds of curricula that counter that snowstorm pattern, as well as community and school policies and community mobilization. Now, this list doesn't mean that everything you do in these areas works. It means there are some programs that have been shown to be effective in each of these areas, and sometimes multiple programs, and that's, again, our good fortune. Over in our last review in 2004, we found 90 programs that passed our good evaluations and positive outcomes. Of those programs, about 43 actually had training and technical assistance materials available, so real people could do them. We didn't have to figure it out from some research article how to do this in my community. So, and that's changed over time too. When I did these reviews to begin with, there was maybe 1 or 2 programs that actually had any kind of training and technical assistance so people could do these programs. Now there's a lot more of that out too. So there's progress. It's glacial, but there is progress. Also, thanks to a guy who's in our state and a different university than me at the Washington State Institute for Public Policy, Steve Oss has done a lot of cost-benefit analysis. This is just a snapshot. He's done it for many, many things. Go to his website. I'm sure that this will be up on my website, and I'm sure that someone will capture it here as well. But there's things that produce, this is the Nurse-Family Partnership, that early intervention program with single first-time moms, low-income moms, found it's kind of expensive, but it really returns a lot in terms of benefit. So it's over a 2-to-1 return for its investment. There's other things that are like a 3-to-1 return on investment. This is our Seattle Social Development Project, which is our school-based program teaching teachers to teach and manage their classrooms better and parents to how to support that work. And then there's some things that are, reaching a bigger multiple. This is an 11-time multiple. This is a parenting program called Guiding Good Choices. Here's life skills training, a school curriculum for the outcomes that it produces. It's about a 20-plus to 1 return for every dollar invested. The third area of knowledge or research that's been produced is on prevention services research, where we learn the lessons applying this work in etiology about what are the risk and protective factors and how is it distributed, and then these intervention tests, and says, how do we now apply that to actual service delivery systems in the real world settings? So we know that there are some keys to diffusion of any innovation. Ev Rogers tells us, first you have to have something that makes a difference. Then you have to make sure that you can disseminate that with fidelity. So whether it's new ways of plowing the fields or planting, or whether it's effective prevention programs, you have to do it the way they were intended. Otherwise, they tend not to have an effect. And then you need some market demand. You need people to say, hey, we want you to try this way of planting rather than that. We want you to try this program rather than the way you've been doing business. So there has to be some funding available. Otherwise, why should we change? Maybe it'll be better crops. I don't know. But, I get a crop incentive program. Okay, I'll try that. Maybe I'll try that. Well, we've had a lot of talk about evidence-based practice from funders, and there's been that pressure is mounting. Even with practitioners who were slow to take up this movement have really taken it up now. When we do our annual surveys of social work agencies that work with us and ask us to evaluate our students, they're always saying, we want you to do more evidence-based practice. Teach them more about evidence-based practice. That's what's important. So the field is driving our curriculum now, which is the way it should be. But our practitioners are asking for that. What we haven't gotten to the point, though, is that our consumers are asking this question yet. And we got to get to that point, and that's the community members, that's people, that's parents. They say, why are you doing that program? They should ask about 3 questions. What's the evidence that that works? What kind of study was it done? They don't have to know the answer. They just have to ask the question. And then give that answer to somebody that knows how to evaluate that answer. My sister, I'll tell you my story instead. Forget my sister. She'll be unhappy with me telling stories on her. I'm a cancer survivor. I had a 50-plus-year-old man at the end of my 50s, and I got diagnosed with prostate cancer 2 years ago. So I happen to be a researcher, and maybe I'm a more active reader of research material, but I got into a whole bunch of biological stuff I never thought I would start reading. I learned all about effective treatment and stage of cancer and all these things, and then what was the most effective intervention? I wanted to know seeds or surgery, seeds or surgery. I did all this research, tried to figure out, finally made a decision. Not being helped by the practitioners the surgeon was going, this is the only way. The seeds guy goes, this is the only way, So they were all doing the same thing to me, but I eventually made my decision. I felt that for my stage of cancer, surgery was the right thing to do. I made that decision. I'm cancer-free. Don't you wish all of us were that kind of advocates for the kind of prevention programming we're exposing our kids to so they can say, hey, what's the evidence of that? DARE, why is that there? It gives the teacher an hour off, but it's not doing anything for the child. What's that all about? In fact, they have 1 less hour of academic instruction as a result. So why are you doing DARE? Get that out of the classroom. But it's not going to happen because there's too many incentives. Somebody else is doing that program. Oh, I don't have to do anything. That teacher can do lesson preparation. They can do other things. I don't mean to denigrate teachers or police people either. It's just that it doesn't work, and they could use their time and resources to much better advantage. What happens? The more market demand there is, the more we can get to consumers and practitioners, the more we have evidence-based programming, we're going to be able to disseminate stuff with fidelity, and it's going to make a difference, and that will change the way we do prevention. And we can see when studies are done, this is Elliott. I don't know if you've heard of the Blueprints project or anything like that, but he has a center for violence prevention, and he has a bunch of programs he's certified as proven effective. Had to have 2 randomized controlled trials, and it had to be demonstrated by outside researchers and beyond the time that the intervention was delivered, in fairly stringent categories. And he's found that they can deliver those programs with high fidelity. It gets a little bit better on the second year than the first year, but they're all doing up here between 80 and 90%, except for one program, and the rest of them are all pretty good. So real people in real communities with the training and technical assistance can actually do this. The real problem is prevention approaches that don't work or haven't been evaluated are much more widely distributed than effective interventions. The installed base, it'd be like no, don't do that. It'd be like having an ineffective operating system, and you say, oh, yeah, it's good enough. It gets me what I want to do. How many of those of us, who made the transfer to Vista are unhappy with that choice? Yeah. I think the new one's going to be better. They're promising it'll be better. I went back to the old version, because it was a lot easier to use. So you have to kind of decide what's the most effective program and try to see if we can get it in place. So this creates challenges for states and communities. Matching tested effective programs to local need. We've got it. One size doesn't fit all. Different neighborhoods have different risks that they're exposing their kids to. We need to make sure that we address the right risks with the right program. This issue of tested effective programs compete with best practice, usual practice, or new practice. We're very faddish in prevention. We're very faddish in education. It's easier to do the thing that I usually do than the thing that's effective, and it's often easier to do something that other people have said is best, even though it's unevaluated, than some new program. because the new program will have to require me to get new training and technical assistance, and it's going to be uncomfortable when I deliver it, and people are going to be wanting to see if I'm doing it right, so that's always, a hassle. And the other challenge for communities is really achieving population-wide outcomes. I can't emphasize this one enough. How we distribute prevention dollars in the state of Washington is we get $9 million a year from the federal government. We don't put a nickel in our own state, but we get $9 million. That seems like a lot of money. Then we divide that into 43 counties. It's capitated, so the bigger counties get more of it, but it's still not very much money. And then those counties say, okay, I don't know how to do this. Why don't you just tell me what you want? So King County is my county. It's around Seattle. It's got big cities on the east side. It's got little towns out in the country. And it's a winner-take-all kind of thing, It's like, well, apply. So there's a little program out in North Bend. There's another program down in South Seattle. There's one in Wallingford. There's one, up in Shoreline. So that you can't get population-wide effects with a distribution like that. You've got to have overlapping programming done well enough and done at enough level that you're saturating the population that you're meaning to change or meaning to serve. So we really got to work on how to achieve population-wide outcomes in our communities. Okay. So for the last 20 years, I've been working on this rather than working on just developing specific models. We've done a few specific model development, but we think the field is in a place now where they have a lot of models. There's a lot of models out there, and the problem becomes from a real-life perspective and a community perspective is how do we develop a system so that communities are picking the right program to match their needs and meeting those earlier challenges that I just had up. So our vision for the Communities That Care vision for achieving the model of science to practice has really been developed by saying what we need to do is we need to empower communities to make their own decisions. We're scientists, and we've been pushed by community members over the last 20 years to do what we do best, provide some tools for them to make these decisions, and provide a process where people can make decisions in an atmosphere that doesn't feel threatening and feels actually pretty good to them. And so they've really told us that they wanted to make the decisions about their community. They didn't want us making them. Don't tell us what the risk factors are, Rick. Just show us what the risk factors are, and we'll make the decisions about which ones are important. So we try to provide educations and tools to communities so they become advocates for tested, effective programs to meet their needs. The education goes along the lines of what I've just been talking to you about, a little more in depth than that. And then we provide a series of tools that I'll show you. Again, the tools that are in that kit are there because community members told us it's too hard to do this. You got to do this for us. We sat them down and said, look, here are the risk factors. We figured out which ones, what they are. You guys sit at your table and figure out which one's the most harmful in your community. So they'd all sit down, and the school superintendent would say, academic failure is the most important risk factor in our community. Police chief would say antisocial behavior is the most important risk factor in our community. Family services would say it's family management and conflict that's the most important. And then they'd all squabble for a long time, and then whoever was kind of stayed there at the table the longest and had the loudest voice or was most convincing, perhaps, or everybody else gave up. Okay, this is what we're going to do. Our priority risk factor is X. So they said, Rick, we got to stop having these discussions. This didn't change anything. It's the same people advocating for the same things as before. So we developed a survey tool so that we could ask the kids, what is going on in their lives, and they could see them displayed. I'll show you that in a second. The other thing they made us do, and which we thought was, well, we finally got the data tool up. They said, now what works? You're the research scientist. Tell us what works. I said, come on, you guys can figure it out. You know what you're doing. You know what programs. I said, no, we want to know what works. You sold us on this idea. What works? You do the reviews. So we then started doing program reviews in various areas, and I'll show you how it all works together. So in any case, the first thing we do is we assess community readiness. make sure that we know all the diverse groups in the communities, what their idea about prevention is, what competing issues there are. Is there a lack of sense of hope, or is there hope in the community? What are they doing with collaboration? Is this the community where we come to the table, put our money on the table, take our hands away, and figure out how to spend it? Or is this the community where we put all our money on the table, some guy says, hey, look out the window, everybody turns, and they turn back, and the money and the guy are gone, out the door, you know? And it's just like, whoa, if that's the kind of community that's going on, and there are many communities that look like that, we've got to build trust first before we can move ahead in this process. We have to build trust in how we do business and how we're going to be able to do this kind of collaborative work together. So everyone isn't ready to take this on. And I try to identify key individuals that are either catalysts or supporters or people who are going to be a champion for this particular approach that can get the right people on board. Because we want to get two different kinds of people: key leaders, key elected officials, mayors, police chiefs, school superintendents, business leaders, key social service leaders, all on board, because they're going to be exposed to this information and decide, do you want to get into this or not? Is this important enough to you to move this ahead? If it is, we're going to ask you to constitute a community board that's going to go through this whole process that I'm going to talk to you about now. And if that is something that you're interested in, then let's move ahead and let's go in that direction. There are 9 days of training and technical assistance. This is not an easy kind of thing. We provide a lot of tools for team building. We provide a lot of tools for community board decision making. We also provide tools for them to collect this risk and protective factor data, as I'll show you in a second, so that they can construct a community profile. We use a youth survey. It's based on the survey that I showed you that data from earlier. It measures 21 risk factors, 9 protective factors, as well as academic and other behavioral outcomes. And it helps guide planners to prioritize these factors, then to select the programs that actually address those prioritized risk and protective factors. And if they do the survey 2 years later, they can monitor the effect that it's had on their kids in their communities. It's 6th, 8th, 10th, and 12th grade students are assessed. They get their profile, and then they have to decide what to do. Well, it could still be there that they say, oh, this is the high risk factor now. What do we do about it? Well, here's how we go about doing that. This is just one data from one school. This is 10th grade school profile. This is protective factors that I talked about before. If protection is low, that's a problem, right? We want high protection. That's a good thing. So here's school opportunities and school recognition. This school is doing good at providing that to their kids, or telling them that are 10th graders are telling them that that's good. And there are some things that are low. Community recognition for pro-social involvement and social and emotional skills are low. The kids are telling their teachers and us that through their survey work. So this community said, oh, that's something we're concerned about, social and emotional skills. They have a risk profile. Again, I know you can't read all these. These are all those risk factors, but they're the community, family, school, and parent individual risk factors. And this particular one is favorable attitudes towards drug use. And I've got to stop now. Is that what you're doing? Okay, all good. Am I done? Am I done yet? And so you can see, we ask, oh, thanks. That's exactly what I need. Oh, you're a caretaker, Bob. Thank you. What a nice guy. You can hear my throat drying up. So, again, it's just a tool for decision making. What this does is it just allows people to see. It's all displayed on one axis. You know, percent of kids at risk for these different things. We worked out the ways of being able to standardize these across risk factors. But here's the one that is pretty elevated, and it's favorable attitudes towards drug use. Favorable attitudes towards drug use. There are other things that they can pick, and I'll show you a little bit about picking multiple risk factors, but there are things that they'll be less likely to pick. right? Why would they pick one that's so low here? I mean, these are risks. So low is no, high is worrisome, low is not so worrisome. Perceived availability of handguns. Not much handgun stuff going on there. And they are committed to school. Remember, they had all those opportunities and recognition, so they don't have a lot of high. In fact, this is the district level. They're much better than the district overall probably because of those opportunities and recognition for kids in school. So they go there and they say, okay, let's go to that prevention strategies, guys, that shows the programs. We've got programs listed by risk factor, and I'm sorry, this arrow should actually be here. Let me see if I can drag it down. No. It's favorable attitudes towards problem behavior, but, school, classroom curricula are in both, and that's what they picked. So let's then go to there's a variety of approaches that can be done here, policies and curricula. And there's a variety of programs within each of those areas that have been tested and shown to be effective. In this area, since this was 10th grade, these are programs that are working in middle and high school. They picked Steve Sussman's program towards no drug use. You go to the community guide, you can see it's in their target age range. You can see the protective and risk factors addressed. It says how does it work, so you can figure out, what does it do? It's, what's the active part about it? What do we know about the effectiveness of it? And here's some references. And where can we get a hold of Steve, and how do we get this program itself? So we really try to provide them with a one-stop place to get that information. They also had other things that they were worried about. We think that 3 to 5 risk factors are the number of things that you should target in a community. You can't target everything all at once. 3 to 5 is a good number. Learn that over time by people trying to do 9 and, utterly failing, or people only picking 1 when they should have probably picked some, things that were more related to each other. So we said 3 to 5. Poor family management and parental favorable attitudes towards drug use. Oh, so you get the idea. We can go and find the strategies guide, do the same thing. But here's a different community. In this community, this particular risk factor is family history of antisocial behavior. It's the most highest risk factor. These others are pretty low. There's a couple other ones that they could do. But different communities have different elevated risks. The other one did not have the family history of antisocial behavior being, it was actually, let's see, family history, it wasn't that high. It was high, but it wasn't, as high as the one they picked. So different communities do have different profiles. Prenatal and infancy programs are ways that people can go. Things like the Nurse-Family Partnership or other prenatal and infancy programs could be picked to address those kinds of outcomes. Nurse-Family Partnership has an impact on moms, teenage moms, these single first-time moms. And it's had effect on themselves, on reducing child abuse and neglect, and on their children's rates of arrest 15 years later when they're at 15 years old. So we then formed task forces on each particular intervention that was chosen, because different interventions are going to require different people to figure out how to implement them. Different to do nurse-family partnership than it is to do towards no drug use in schools. Towards no drug use, got to have school and principal and teacher buy-in to do the training. Nurse-family partnerships, got to get the public health nurses and health system, activated in order to put that in place. You got to get the right people involved, and you also have to look at your outcomes over time to see if you need to adjust your programming. This goes around in a circle. It's thermostatic. Once you do a 2-year plan, you revise it, look at your outcomes, see if things are going the right way, maybe adjust your programming. New risks may come into play. Old risk may drop off. There's lots of things that can happen. This process to go through one cycle of this readiness through developing a strategic plan can take 6 to 9 months. It can take a lot longer if your community isn't ready. Readiness work can take a year or more, and some communities may never be ready, and I don't think that's the case in Baltimore. There's lots of on-the-ground action and lots of community support happening here. Then people implement their programs at about 1 year, and then about 1 year to 4 years later, after they start implementing programs, they should be able to see some change in risk and protection. That's just from the programs that have been evaluated. That's about how long it takes, depending on the program, to see a change from the literature. And then a year beyond the implementation, again, depending on the program, you see some change in positive and negative outcomes. That may take longer. The nurse-family partnership, obviously, those kids, it takes a long time before they get arrested. They're not getting arrested as 3-year-olds. It's going to take some time to wait for some of those outcomes later on. So we've tested this program in a randomized trial. It's a 24 community randomized trial in 7 different states: Washington, Oregon, Utah, Colorado, Kansas, Illinois, and Maine. And it's got about 2 control and 2 experimental communities in each of those states. And we were, like any other agency in the community, we had to get a lot of people on board to fund a community trial. But it was really nice that there was such strong support for the trial. Oh, I don't know why I put this in, but okay. You want to see, it's actually a trial with a multiple baseline before it, randomized to intervention, and then we did those cross-sectional communities that care surveys, both for communities to do their planning with, but we also picked up a longitudinal panel of kids that were in 5th grade in 2004, and that's the results I'm going to show you today based on that longitudinal panel. We picked up the same panel in both experimental and control, or intervention and control communities, and we assessed everything else under creation. Key leaders and what they thought about things. We looked at all the different prevention resources. We looked at teacher surveys of what they were doing in their classrooms, as well as board surveys. And we had everything the same except for the board surveys in the control, and obviously they didn't get the intervention. Our model of change says if we do this training and technical assistance and get community teams up and running, they should adopt this prevention science framework and collaborate more. And we have a paper that Rick Brown, one of our colleagues at SDRG, has done, showing that we have indeed stronger adoption of this approach, as well as much stronger community collaboration as a result. And we also then think that they should be choosing tested effective programs to implement. And in fact, our 12 communities did. They picked a variety of different programs, school-based programs, after-school or community-based programs, that all have an empirical warrant for being effective, and family-based programs. And you can see that in the first year, they got about 27 of these 12 communities, so that's about average of about 2 per 12 communities, about 2 per community. And they got probably at a height of about 3 per community by the time the 3 years was up. And the interesting thing for me is, we had a lot of trouble, or they had a lot of trouble getting school-based programs in the first year. Only half of the communities got these school-based programs in. Doesn't mean you have to do one, but they wanted to, but the schools was saying, not in my school, I'm doing achievement testing. I can't let these things in. The community board, though, was able to convince the schools so that by the end of the time here, all 12 communities actually had school-based programs in. And it's the strength of a community board to actually make change. So one of the nice things for us to see was that community empowerment indeed did lead to changing attitudes and behaviors among school personnel to get more of those in. And the other thing you notice in these years that you start getting these stars are community investment in the programs themselves. We provided a certain amount of money for them to do these programs, but they started doing investment, and now we're watching sustainability after in 8, 9, 9, 10, and 10, 11. We'll be looking to see how long they sustain these efforts. So what do you get? Can you get community-wide outcomes or not? That's the question. And so there are about 10,000 kids that are in the age range that we picked. We picked this 5 to 9 age range. We only picked that for the trial. It's not something that Communities of Care limits itself to, but to do the trial, we wanted to pick a panel of kids to follow, so we picked that time frame. But there's about 10,000 kids in these communities that are in those ages. We didn't get that many. We got about 10, 15% of them in the first year, but by the by the third year, we were getting about half of them exposed to the school curricula. After-school programs are often targeting higher-risk kids. This is overall probably about 16 or 17% of the kids. That's about right because they don't really, not everyone needs these higher-risk services. And the parent training programs, though, was our big disappointment. These were for everybody. We were hoping to get these kind of figures, or at least half of these kind of figures every year. But we probably, again, got about 15 to 18% of the kids' parents exposed to it in this age range. We assessed attendance, adherence, and dosage of all the programs. We did a whole bunch of checklists. We got community board members to do the checklists as well as the program implementers. As a result, we got high and strong implementation of most of the programs by the second year. Most of them were in the 80 to 90 time frame, similar to the Blueprints project. Not all of them were. They actually discontinued this program in the second year because it was too difficult to implement. These things happen. And so we wanted to see now, with this kind of exposure, 15% of the high-risk kids, or 15% of the population getting the high-risk interventions, about 15 or 18% getting the parent interventions, and about half getting the student interventions. Is this really going to make a difference in decreasing risk and enhancing protection? The 3 to 5 risk factors that they prioritized were in that list. Not all communities did all these, so I just wanted to show you the things that people did. Things in the family were prioritized. Things at school were prioritized. Individual and peer factors were prioritized, I guess commitment and academic failure. And some normative things were targeted. And we did see a change, a significant change in risk. Here's the control community. This is what normal development gets you during this time from 5th grade to 7th grade, a big increase in risk. That increase in risk was blunted among our CTC communities. And we had a range of positive outcomes on particularly drug use and delinquency, and alcohol use, cigarette smoking, and smokeless tobacco use and delinquency initiation was reduced in these communities community-wide. And we also had some impact on current drug use, not just if I ever used these drugs, but if I used in the last 30 days, on alcohol use, binge drinking, tobacco use, and delinquency. And just to show you about the size of these effects, here's the alcohol effects. We reduced this by about a quarter, the kids using in the last 30 days by about a quarter. This is probably about a third in binge drinking reduction. Maybe a 40% reduction here in smokeless tobacco, and a similar reduction in delinquent behavior. If you want to find these materials, they're at this website. Again, you will get these things later. It's just preventionplatform.samhsa.gov. And the night of town hall meeting, we were lucky enough to have Gil Kurlikowski and Fran Harding from CSAP and Nora Volkoff from NIDA do a press conference. And I just wanted to share with you, if I can. Oh, look, it's not here anymore. I love my life. Here it is. No, it's not here. There we go. You went away. I'll have to do this again.
Hello, I'm Nora Volkoff.
Nora, see you again. I think this gives us hope for the entire field. This is Gil Kurlikowski reflecting on the outcomes, but also on prevention and treatment more generally.
Thank you. Before we continue with the questions, and we can have a few more, I wanted to say that Director Kurlikowski has been called back to the White House. This happens. So I'm going to give him a chance to say a couple more words before we continue with the questions.
Good, thanks. I can't tell you how much I appreciate NIDA and the people of Maine and everyone for this. Seeing the success of communities that care and seeing the work that's being done, and the collaboration in that community in particular, I think, should give a lot of heart to a lot of people across the country. And when the president looks at a national drug strategy this year or next year, you can certainly count on the fact that prevention and treatment will play a very significant role, and it has to be one that involves everyone. So thank you so much for the opportunity.
Thanks for participating while you're unhooking. Mrs. Mike unhooked. We'll continue with some more questions.
Yes, we have a new day, a new administration, and I think prevention and treatment are finally going to get the dollars that interdiction and enforcement have gotten in the past. And so I think we're very lucky to have our current administration in office, and really lucky to have Gil Kurlikowski and Tom McClellan in the Drug Czar's office. So I think those are really positive things. You can see that NIDA, it's an hour-long thing. They show people from communities talking about the what's been done in 3 of the 12 communities. And so you know this. Strong research base. Early prevention and prevention during adolescence, Snowstorm and Snowball, both important. Programs and policies that reduce risk and enhance protection have demonstrated efficacy. Unfortunately, the programs that don't work have a bigger installed base, but there is evidence that we can advance public health and achieve community-wide or population-wide outcomes by using communities that care. Thank you so much, and I look forward to the comments.
I'd like to invite the panelists to come up, and if we could have the lights up from the back. And while they're coming up, I will introduce them from left to right. Behind me is Douglas Miles, who is the Bishop of Koinonia Baptist Church here in Baltimore. Bishop Miles is a Baltimorean. Went to high school at Paul Laurence Dunbar High School. Went to Johns Hopkins undergraduate. Went on to get his master's degree in theology and then his doctorate at Wesley Theological Seminary. He also has an honorary degree of divinity from Virginia Seminary and College. Not only is Bishop Miles a pastor of tremendous importance, he is a community activist of at least equal importance. He is the co-clergy leader of BUILD. For those who aren't familiar, BUILD is Baltimoreans United in Leadership Development. It is a major community development initiative that right now is targeting work in the Oliver community. He has also been a co-chair of the Mayor's Summer Youth Work Program, and that only scratches the surface of what he has done. To his right is Rafael Lopez. Rafael Lopez is not a Baltimorean, except by transplantation. He grew up in California. He was in San Francisco, the deputy director of the City and County Department of Children, Youth, and Family Services, and then in Los Angeles before coming to Baltimore for 2006 to 2009. He was the executive director of the Los Angeles Commission for Children, Youth, and Their Families. He has a 15-year history of working at community-level initiatives. He was the youngest person to be elected to the city council in a community in California where he lived. He is the first person in his family to graduate high school, go to college, go on to a higher degree. He got his master's degree in public administration from Harvard University, and he is now the director of the Family League here in Baltimore, and we are exceptionally fortunate to have him in our community. And to his right is Professor Phil Leaf, who is well known to many of the people in this audience. Phil is the Senior Associate Director of the Urban Health Institute. He's the Director for the Center for Prevention of Youth Violence. He's a professor in the Department of Mental Health. He is omnipresent at just about everything that relates to Baltimore. And equally or more important, he has been instrumental in advancing a lot of community initiatives. So this is an opportunity that we would ask you to reflect on what you were hearing and what you see are both the issues and opportunities in Baltimore. Bishop Miles, would you like to lead off?
Thank you, Dr. Bloom. Professor Catalano, thank you so much for coming and sharing with the Baltimore community. And it's my understanding that earlier today you had opportunity to meet with others from around the city, and it would be my, I would say hope, but in the theological sense, hope is expectation. It would be my desire that city officials and police leadership were present for your presentation earlier today. Much of what you said today is what the group that I share with, the BUILD organization, has been advocating for the past 15 years, and our advocacy comes out of actually talking with young people in what we call house meetings, and others would refer to as focus groups, to determine from them what they see as the needs for young people in this city. And in our discussions over the past 15 years, the primary thing that young people in this city say is that adults in the city don't care. Because if we cared, we would not allow to go on in this city what we allow to go on. And out of those meetings, they suggested a couple of things that fall directly in line with the things that have now been proven to be successful as what they see as needs. One, safe recreational opportunities as alternatives to playing in streets, to being run out of neighborhoods simply because they're gathering on corners. The second thing is youth employment as an alternative to the drug culture, offering the first opportunity for employment to most young people in the city. Third, after-school programming, so that they have some place they can go between the hours of 3 and 6, between the time that they're out of school and the time that many parents get home. And lastly, decent and affordable housing for young families. It's amazing to me how the young people of this city see the blight in this city as spearheading and driving much of what's going on in terms of the violence, in terms of the drug activity and other negative things that happen throughout this city. The one area that I think is missing in the presentation that probably, and I've been advocating for, again, we've been advocating for the past 5 or 10 years, is to take a look at grief and how it plays out in inner city communities, and not just grief in terms of loss from violence, but grief in terms of many young people are grieving because they've lost parents to AIDS, they've lost parents to incarceration. You talked about mobility from one community to another, but many of our young people experience mobility within the community where they live, moving from one house to another. And until most recent years, with this new CEO of schools that we had, most Baltimore schools on the same grade level had different curriculums in different schools. So if a child moved from one block to another, he or she was at a disadvantage when they showed up in the classroom because it was a totally different curriculum than they had come out of. And this uniformity of curriculum, I think, has helped stabilize some of the test scores in this city. This community that cares is where Baltimore needs to be heading. instead of a police commissioner talking about young people as animals, as not being worthy of being in the harbor, of taking the activity back uptown, when if it's negative activity, it should not be tolerated anywhere. And we need to start looking at approaching our youth in the holistic manner that you suggest by your research and by proven results. My thanks to programs in the city and leadership like Mr. Lopez and the Family League of Baltimore that initiates and directs programs for after school, for Phil Leaf and others who work diligently. And I just ask the Baltimore community, be patient, just a little while longer. You're going to see a major declaration coming out of the faith community.
Sounds promising. Mr. Lopez?
So thank you, Professor Blum, for inviting me to participate in the panel, and thank you to Dr. Catalano for his presentation. A couple of thoughts to build on the good bishop's comments in terms of things that sort of I thought about in the context of the presentation. Certainly want to open it up for discussion to the group here. So a couple of things that I was struck by was the theme of risk and protection. And what it made me think of was actually risk and protection in the context of systems of adults who run the various systems that supposedly reduce risk or protect communities. And I was struck by sort of the ease with which you demonstrated, based on the research, what worked and what worked when people actually put their minds to it. But what struck me as the next step is actually how hard it is to actually do that work. The heavy lifting of change in communities is extraordinarily difficult because ultimately people, and most often adults, who run these programs, who are the directors of nonprofit organizations, who are the heads in some cases of churches, who are in roles like mine, don't want to change because they have a vested interest in the maintenance of their organization. And so I was struck by the importance of actually naming that beast in the context of community change, because it is oftentimes we adults who are in actually very much the way of institutional change and change in communities at a neighborhood level. So change is hard is one of the things I wrote down when that particular part of the presentation. Secondly, the risk in change itself. The risk of changing models. So what does it look like to actually do an analysis of a current program that you have running, whether it's in Baltimore or somewhere else in the country, and say to yourself, what would it actually take to dramatically change this program because we know it doesn't work? And I'll use the DARE model because so many police departments across the nation have actually implemented and have touted DARE as a great way to prevent the use of drugs, when in fact we know it doesn't work, and we knew it didn't work for many, many years. But actually changing that and actually removing the funding from that particular program out of general fund budgets in cities across America is yet to be accomplished. Yep. So the risk and change is extraordinary. The cost in evidence-based programs is another piece that I thought of listening to Dr. Catalano. A lot of the models that were up on the screen around the Olds model in home visitation, around the Abecedarian project model in North Carolina, all those have models of success built into them, but they're also extraordinarily costly. So building on the issue of, we know that those models work, we don't necessarily refute the data, but the risk and change and the risk of moving to that without the financing in place that either leverages federal or state funding or local dollars in the case that's managed, for example, by the Family League, is very difficult to do. So I want to make sure we balance that. Fourth issue that I wanted to mention was the issue of politics and advocacy, which the good bishop touched on. We function in cycles in this country around from the federal level in terms of presidential elections, and really less than a 4-year cycle, to a local election cycle that's often 2-year driven. So people expect and want and demand change now, and they're not going to wait for 3 to 5 years for the evaluation to take place. So I think that we have to constantly balance this notion of what we know works based on solid scientific research, and how do we actually achieve some sort of a balance in terms of getting programs on the ground in the context of political forces that are often, not often that are simply powerful, but in fact capture the imagination and the attention of people. So when a child is killed in a street, as is often the case here in Baltimore, as you all know who watch television or listen to the radio, we are entranced by that death. And it's the crisis of that death often that moves us to change, not oftentimes based on evidence-based practices or research or a scientific method, but in fact, who is often able to speak or yell the loudest and garner the most attention of the politics that be in a particular city. The fifth point that I wanted to point out that struck me in the presentation that's clearly also the case for Baltimore is achieving population-based outcomes at a program level versus replicability at a population-wide level. So you could have, in the case of many nonprofit organizations in Baltimore City, really solid programs that are getting kids to graduate from high school on time, that are reducing chronic absenteeism, that are increasing the resiliency of young people based on a youth development model, that work really well for a subset of population, but there's no replicability and no way to turn the curve or actually make a case for population-wide change. So that's another huge issue. The two other points that I wanted to make, and then I'll wrap up with sort of an overall thought related to the presentation, is the replicability factor. I was curious about, in the presentation, the data that drives the 7 state models that make up the communities of care, and thought about the race, class, culture issue that's really important to understand in terms of how those communities function. There are certainly neighborhood differences around how they view themselves around resiliency, but I would want to know a little bit more about the race, class, culture factors that are certainly prevalent in those 7 state models, as well as what we would look at in Baltimore, both in terms of existing population here and both newly immigrating populations from other parts of the country to Baltimore and certainly other countries. The last piece that I wanted to mention is the issue of accountability, and that I was struck by in this particular model, and whether it's this model or any other model that we choose to take on here in Baltimore and certainly across the country, is that there has to be an almost religious approach to accountability, because whatever the model you choose, and I use that word intentionally, Bishop, around accountability, this is not just about performance or reports or evaluation. It's about what you're getting money to do, and too often, people get money to do something and they don't get it done. They don't get it done on time. They don't get it done according to what the money was ultimately intended to do, and there's no accountability for that mechanism. And I want to mention accountability as a last piece, because it's not accountability to the funders or the governments or the many agencies. It's accountability to the people that you're serving. That's right. And it's the children and youth and families who are supposed to get these programs that often do not. And so I wanted to end with that point, because I was struck by that across the presentation, but really I think it's something that we have to be very clear about here in Baltimore as we think about replicability of communities of care or other kinds of models that are certainly being discussed in the community. And that ultimately is about being mindful of the people that we serve.
Thank you very much.
Thanks.
Okay. One of the reasons why maybe the mayor isn't here is actually, if one looks at the last report for the mayor's office youth empowerment strategy, you'll find that communities of care is the central vehicle for driving change within the city. Of course, it never got it implemented, but Rico's last foray down to Baltimore was very successful in terms of doing this, and I think it comes back to something several of the speakers talked about, and I think it was more implicit in what Rico said as opposed to explicit. But that what the model does in the communities where it works is it actually creates a decision-making process that includes both experts but real community participation. And it's hard to have accountability in terms of who's actually benefiting. Many of us at the university benefit primarily by being able to get grants, and we do equally well showing things work or don't work. I mean, our salaries get paid. We can write articles on both of these things. The issue in terms of if one just has to look at a lot of cities, not just Baltimore, in terms of how long it's taken to get people concerned about educational attainment, how long it's gotten people concerned about people having access to jobs, substance abuse. I think the positive part is that as we heard on the little clip from Gil, the federal administration actually would like to have outcomes as opposed to simply funding things. The accountability for most programs not working is the people in the community lose the funds, the administrator at the federal level, the project director just gets another project to administer. So how do we create accountability? How do we create consumer buy-in? And I think that the challenge is not just talking about programs, many of which are on the effective practice list, that essentially require hiring lots more people to sort of teach people how to do things, which are necessary. But how do we take advantages in places like Baltimore, where we have a build, where we have a number of community-based organizations. The Oliver community came together to recently get one of the drug prevention community programs, and will be engaged in this kind of sort of assessments of collecting data and making decisions. How do we not just sort of reconstitute the same groups which, at least in this city, have not been that effective in being able to implement things, but start including those programs from the communities and those neighborhoods, because as Rico said, not all neighborhoods or communities are going to be ready to do this from the start. On the other hand, some of the ways we may have constituted communities, looking at the way the Build church community, school collaborations have gone, that it's not one community in the city, because Build is in a number of different communities, but they have a critical mass in a number of communities. As he said, they actually even have a process for trying to understand what some of the needs are. If some of us who have access to different kinds of data could also get that data brought to the youth and the community groups in there, as well as the professionals, many of whom live in the community, and in the Build collaboration, many of the family members are also professionals. They happen to have children, and they're involved, and they're church members, that people are wearing multiple hats, but they also bring their expertise as teachers or employees of different city agencies, or just having their own businesses to the process. And I think that the challenge in large urban communities, as opposed to when you get a community in other places, you have the full continuum. You have the mayor lives in that community. By definition, the police chief lives in that community. The superintendent of schools lives in that community. But most of the teachers also live in the community, and so you're able to bring together a very diverse group of expertise. Where if we take a community in Baltimore, we have a much more truncated amount of expertise, just because we have lots of people who don't live in the city who work in the city. We have lots of communities that are more homogeneous in terms of income and opportunities, and unfortunately too many communities in Baltimore City have limited incomes and opportunities, which means that the expertise from the personal perspective, not that parents aren't important, but being able to make decisions and hold accountable, there's much less ability for some of these people to hold accountable. And again, I think I think those are the keys for Baltimore City or other communities really moving forward, and that's where we really don't have the evidence-based practices. I think how to effectively work in the larger cities, not necessarily turning the city around entirely, but being able to support efforts in those neighborhoods, whether it's a Cherry Hill neighborhood or an Oliver neighborhood or a greater East Baltimore neighborhood. So they can focus on a limited number of things and have successes, and then iterate on to the next success, or things that we as a School of Public Health, as well as other people who are interested in this question, really need to do a better job.
Rico, let me turn it back to you if you have thoughts, reactions, comments.
Well, this is the biggest delight of my current life, to have wonderful people with great backgrounds and commenting on our work. It's one of my biggest career highs to have people engage on a real basis with my work, because that's what you're thinking. How would this fit? How would we make this fit in this particular community? That's really what I've tried to make my whole career based on, is trying to find ways to use science to help in local decision making as part of our mission at the Social Development Research Group. And so I just want to make a few comments beyond being so honored by the comments that have been talked about so far. I think grief is a really good issue to think about in urban communities. I think it's a really good issue. The transition part that we were talking about, I was talking within communities, because we know lower income communities, people are moving around block to block, but when they have this problem of being behind in school, just by moving a block, because you have different curriculum at different schools. That's a big block, particularly in early grades, because you can get right off the track. That's a big issue. And grief and how that really plays out in communities and all the loss, I think that is something that it probably isn't well captured and has to be thought through a little bit more. And great idea. Thank you very much for that. And I think, and thanks for all your great comments as well. And I'm glad you guys are finding the same things that we are. Those are good. And Raphael, it's a really important issue that you raise, and it is often. I hope I can say this out loud and not get run out of town quickly, but it is often the gatekeepers that are keeping effective services from the consumers, and it's been a struggle with me, and that's why one of the reasons that on our community boards we try to have service providers, but also community members, because we have to have both groups, in a sense, in a dialogue to say, hey, no, that sounds like a good idea. I think we can try that. Whereas a service provider say, oh, I don't think our community's ready for that, or that they're. So it's an important dialogue to have between community members, those who are actually serving, and you said they have to be the ones thinking about accountability as well, because we are accountable to them. They're the ones we're serving. They need to have a dialogue with our service providers. We thought of various models, in fact, experimented with various models along the way. We had only service. We said, oh, we'll just get the service system people involved, and that's where we'll stop. Or we'll just get the key leaders involved, and that's where. Or we'll just have grassroots community boards. They all need to be together in some way. They need to have create a dialogue in some way so that gatekeepers aren't gatekeeping, and the community members are advocating for and learning about effective programs as well. So I think it's a really important challenge that we face in this time, because, as you say, risks of change are high, and at the same time we have to figure out what the financial models are. How are we going to do that when politicians only want to wait 2 years? How can we do these things? And at the state level, I think you can, because you have a body that's reelected and other things. At the local level, it's a lot harder to wait for our outcomes. And I think that's it's a big challenge that we all have to face.
Maybe we could take a few minutes here and open it to the group for comments, questions.
Could I just make one more comment?
Sure, of course.
Just because I was struck by what you said, Phil, and I just think that we all have to recognize this. Truncated expertise in urban communities. It's a very interesting idea and concept, and it's, you don't necessarily have all the resources. When we were doing Seattle-based interventions in highly diverse communities in Seattle, one of the things that we found was that we could create good boards. They were really strong and committed boards, and our board members that were the strongest and most active moved. They moved on to other things, moved on to other neighborhoods, and that this also was, not only was there truncated expertise, but it was being stripped as we would do that. So it really required a continual capacity building in those communities, and really a much bigger focus on that capacity building and renewal of that capacity, because it wasn't the same thing where you could count on somebody to sit on a board for 3 to 5 years. They might do it for a year or 2 years, but then the people who were there were moving on. We worked with homeowners. That was a good idea, in some ways, because they'll tend to be there longer, but it really is a big issue, and I think you point out that it's an issue at urban communities, and I would tend to agree, and we have to solve that problem of community board membership, education, and capacity building, and the turnover that we're going to have, and we want to have in some ways, because that's how they're going on to better things, but who replaces them, and that's a big issue. Sorry, I just wanted to make that point.
If we can just go down the row here, we'll take 3 questions, quick answers.
Or maybe no answers.
2, 3.
I noticed in your presentation when you talked about your exposure in the community, from communities that care, that you had
It is a very big piece. When we do parenting interventions, we're doing them now rather than the communities. I mean, this is all community-owned and driven. That's when we do them, we do everything we can, and we have every trick in the book, and we taught our communities every trick in the book. We get about 40% of parents. That's about as good as we've ever been able to do. And that's going both ways. That's saying, okay, well, it's a group training. We're trying to get people in, and we're going to, provide transportation, and we'll get phone trees and buddy systems and incentives, and we got local foundations to give us money so that parents could evaluate the homework. That was that idea, and give them $25 to evaluate the homework. We had poster contests, so the kids would do posters, but their parents had to come to the parent training meeting, and if they were going to, be judged at the end and see who would win, they had to be there for that. We had, food. We had every conceivable thing. Still got 40% of the population in, but we were able to achieve broader outcomes by getting 40% of the population in. So I think Dick's both has some data showing if you could get 30% of the parents involved in a community or in a school, that you can show more school-wide effects, if you will, of that kind of program. So we don't have to get them all. But the other thing you have to know about parenting is that it's something that you have to be there, and you have to be there, and you have to be there. It's just something that it's just the way we do things. We should have in this country a requirement for kids getting out of elementary school. Their parents have to go to some parent training class. I mean, we have a lot of that going on at birth time. That's going to be scary. We better do something. It's a much higher rate of people having birthing classes than it is any other parenting class. And, it's one thing to go through that, and it is scary, but boy, the rest of the 18 years plus are pretty scary too. And, we need to do something to, make sure that happens more regularly. And we have to change norms to get that to happen. Harder to do. It's, again, my biggest success is 40%.
Tony.
My question is an interlaced question. It has to do with Raphael's comment on the race, cultural,
yes.
class. That's a big one for me. And what I thought about in your 6-state strategy, I wondered that when I saw that slide, I wasn't really puzzled by it. It looked like the Midwest and West Coast and upper like that. It seemed like Illinois was the only one that maybe you could draw some stuff that might be applicable to Baltimore if you went towards Chicago, if you went towards the inner part of Illinois. My question was, have you been able to draw some data from that might be applicable to Baltimore?
I think, the best place is not in this trial, because we were trying to look at smaller intact towns rather than in larger cities. But the community set care is in a quasi-experimental study has been evaluated in the state of Pennsylvania, and that's probably where the better data is there. Mark Greenberg and Wayne Osgood and Mark Feinberg at Penn State have done that study. We haven't done the study. We did the training and getting people moving ahead in Pennsylvania, and it's spread through the state, and they have really good data on it. And so I think that's probably the very best data. And again, we were trying to do that so we wouldn't get contaminated, all the science stuff. No contamination between communities and that kind of thing. So we tried to take it as a smaller town study. The biggest town was 40,000. The smallest town was like 2,000.
Michael?
I'm wondering why the Community That Care program was approved but not implemented in Baltimore. What happened between the approval and the implementation?
Budget problem.
What?
A budget problem.
Budget.
Essentially, there wasn't adequate funding to hire, essentially hire the person who was going to be the local coordinator in the communities that were.
I would argue that it was not budget problems. It was lack of priority rather than it being budget problem. We tend in Baltimore City to find money for anything we really want to do, even in this time of economic chaos. But when it comes to our children, when it comes to strengthening communities, that's always put on the back burner.
Was this before Alonzo?
It was not a change of administration. It was under Mayor Dixon. So Mayor Dixon approved it
comment on the $200 million facility that is being built in Baltimore City down the street for women and children. Instead of, I mean, they can find money and sometimes to build another prison facility, but that money can't go on the front end for programs that we know work. And it's not as though there's not data to support that. That's evidence-based, but yet we keep building prisons, and then we can't afford that. But we find money to support that part of it. It just doesn't make any sense to me or kids or anybody else.
I don't think that you would have much disagreement.
But somebody was able to stop the prison from being
It becomes a matter of politics. And until our children are taken out of the politics of Baltimore, and no matter who's in office, we're making certain demands upon them, then this will continue to happen. We have to depoliticize what's happening to our children and say that this is a community concern no matter who's in elected office.
Okay, we have two final words or comments. 1, 2, and then we will continue this, but we will do it over a reception.
I'm thinking as you speak of the Tippet campaign with Safe and Sound, and what they want to do is exactly what you said, to take all the money that's dumped into punitive programs for youth and put it into youth opportunities. And we need to get behind that campaign and make it tip. Change the budget. Do what you said, Bush Mom. Prioritize kids.
I guess I was struck, and particularly by what Mr. Lopez said about so much of what drives what happens in communities having to fit into some political aspirations. And I'm struck by how much we think we can really achieve in a community that's not initiated from the community.
That's true.
You know, I wonder about that, because if the driving force is not the community's need, but we want the community's buy-in, how realistic is it?
I think that if there is a core message that I take away from the Communities That Care initiative, it is that. It is that without the political superstructure and the community infrastructure together, without that, it doesn't even get off first base. That's sort of a necessary precondition. And certainly what I hear from the panel is we've got a long way to go to get to the point where we can start having the conversation of how do you implement best practices. Because without that, you get piecemeal, 2-year wonder projects that are someone's pet initiative at $100,000, $1 million, $500 million, and they're gone, and they do nothing. And we do find a lot of money for a lot of programs that go down the tube.
Even more basic than that, and he can't say it, but I can say it. The Family League is facing possibly another budget cut in this cycle, when we're already not putting 1/10 of what we need to put into after-school funding. That's going to happen unless there's political outcry.
And then the response becomes, we need more prison facilities.
Yes.
In response to that, I think that we have work to do. Thank you all.
And I'll do